What's a typical week going to look like in the University Park program that you guys have been designing?
Absolutely. So for the first year or so, the week will be similar in nature. Our students will spend about 3 mornings in a clinical immersion. It will be a longitudinal relationship that they develop in either a family med or an internal med clinic. There will be several providers, but that location will stay the same for them, and their role will change, but they will be there consistently. And that might be, Monday, Wednesday, Friday morning, so we'll stay with that. To accompany that, then we have our IQ groups, or inquiry groups, as we call them IQ groups, but they're inquiry groups. And those usually pair up nicely with the clinical immersions that we have. So we have 3 of those a week as well. They will continue on for some time in the student's education, and they are Monday, Wednesday, and Friday afternoon. So you can see that Tuesday and Thursday there's a lot of free space in there, or white space in there for our students to take the time to do independent learning. But kind of over the year and a half, the beginning part of that curriculum, we also have some other components interspersed, anatomy sessions, collaborative science tutorials, and other extracurriculars that I am sure our medical students will become involved in.
And you yourselves, of course, because a reminder to our viewers, you're going to be taking this very curriculum that you've designed.
Absolutely.
You mentioned these longitudinal immersions and IQ groups. Tell me a bit more about those.
Yeah, so essentially we're coming in, as Morgan says, several days a week to the same clinic, to the same primary care clinic, and the core thing that we're trying to build there is trust. So initially, in the first month of medical school, an incoming medical student does not have all the medical knowledge they need to be a doctor. That would be an unreasonable expectation on our students. But they do have a variety of other skills as a means of gaining additional skills along the way and gaining trust along the way within their healthcare teams. So the plan is not just to have those students work with one doctor and shadow them or try to clerk with the doctor or anything like that. At the beginning, we'll be doing a lot more patient navigation, care coordination sorts of skills, in addition to learning about other members of the healthcare team and finding ways to gain those skills, and in doing so, learn more about the healthcare system. So learning some nursing skills and doing some rooming with nurses as a means of patient interaction, getting an opportunity to spend time in between the rooming that the nurses would normally do, and when the provider comes in, to have one-on-one time with patients from the very beginning. Even if you don't have the medical knowledge, you can still learn someone's story, you can do patient navigation work, and you can gradually learn to get your medical skills and your narrative medicine skills going that way. And then when the provider comes in, you can start out by maybe doing more assisting roles, and over time work into a more clerkship role there. And the key to all of this is exposing our students very early on to many patients, and many patients in a primary care setting, such that they'll have a wide variety of medical issues that they're trying to work with. And so that will help our students hopefully have intrinsic motivation and curiosity to then go out and say, I met a person today and that person is struggling with pancreatic cancer. And I don't know a lot about pancreatic cancer as a first-year medical student, but I want to. So they walk in the classroom, they walk into their inquiry groups, they walk into their white space of study time, and they have questions that they want to answer, not that the textbook tells them to answer or that a worksheet tells them to answer.
So there's so much interesting to unpack there, Tom. The first is this idea of learning interprofessional roles. A lot of us struggle in medical education with how to offer meaningful interprofessional education, because of course we all work in healthcare and interprofessional teams, but you're going to be embedded in an interprofessional team and learning with interprofessional colleagues from the beginning. So that's exciting. And then it sounds like you're also going to add some value to these clinics. I'm thinking I would love to have an extra set of hand in my clinic to help room patients, get patients where they need to go, navigate our complex system. So is that part of the design as well?
Absolutely. I think both of those things are core to what we're trying to do in our clinical immersion. So as you said, with the health systems understanding, oftentimes in clerkship roles and in medical schools, the worry, or one thing that we're concerned about, is that the medical students will act kind of as mini doctors that eventually grow up into big doctors. And that's one thing that they need to learn how to do, but that's not the only thing they need to learn how to do in a clinic. They need to learn what everyone else is doing in the clinic, because they're part of a healthcare team now more than ever. And so understanding what the nurses are doing and how that affects the patient, understanding what people at the front desk are doing and how that affects the patient, care coordination, nurse practitioners, physician's assistants, there's all kinds of people working as part of helping that patient. And so to work with those people to understand those roles and to understand the interconnections between them, and that doing so will help us as we grow up into, hopefully, clinicians that can navigate that team and work as one of the leaders of that team.
So tell me more about these inquiry groups in the afternoon. Is it pure discovery learning? Saw that patient, suffering from pancreatic cancer, I'm going to go look up a resource, or are some of them set? How is that going to work?
So an inquiry group is when we meet Monday, Wednesday, and Friday in the afternoon after our clinical immersions. And a group of students will meet with a faculty mentor, and we'll sit down and we'll bring back patient cases that we saw in the previous week that interest us and that we have questions about. And we vocalize these together as a group, and we decide upon a couple that we think are interesting to discuss throughout the coming week on Wednesday and Friday. And throughout this process, we're writing clinical case summaries to get some practice on actually doing a history and physical in a safe environment where our mentor knows that we don't have the best skills, so we can get some practice there. And we're also coming up with some learning objectives with our mentor. And the idea is that we use these learning objectives as shared jumping off points so that everyone can have an equal footing on what we're studying in our white space on Tuesday and Thursdays, so that when we come together on Wednesday and Fridays, we can have a general idea of what everyone wanted to cover, but then we can go deeper. And after our sessions on Wednesday and Friday, we can ask more questions that we can answer on our own time.
What's also really exciting about these inquiry groups is that the contextual basis for our learning are our patients. We're not learning from textbooks. We are meeting patients, we're engaging with them in the healthcare practice, understanding all the comprehensive dynamics that are going into their healthcare. And after meeting these patients, we develop these clinical case presentations that can allow for elaboration and expansion of our curiosities. And it's liberating as a learner to be able to explore that instead of just being confined to what my assigned scripted learning objectives are. And so our curriculum is very asynchronous in nature, which, you know, as science people may seem uncomfortable, but it's actually quite the opposite. It's exciting because you never know what you're gonna see in clinic. So it's galvanizing in a sense because it's not typical.
I think also by rooting it in the patient case presentation, as opposed to a specific list of diseases, you'll be able to expand that patient presentation to compare and contrast and to learn about other diseases that may not have come up in your patient practice.
Yes, so that begs the question, you know, we are in an internal medicine or family medicine, a primary care sort of setting. There are going to be diseases or things inevitably that we will not come across, more obscure conditions, you know, like Wilson's disease or PKU. And, you know, a lot of people that are learning about our curriculum are curious about the sort of breadth and depth of our curriculum. How robust is our curriculum? How well is our curriculum going to prepare medical students as any other medical school? And to address these potential gaps where these obscure conditions have to be learned, have to be addressed, we have the collaborative science tutorials.
Yeah, so tell me a little bit more about those.
Absolutely. So as I mentioned earlier, and as Vanessa has been alluding to, we're very conscientious about these potential gaps. And one of the concerns we've had this year was actually basic science. Most of, if not all of our faculty mentors are clinicians. And so how do we account for that learning and that expertise that we need to look to sometimes because we have questions and then we have more questions and then more questions and we want answers. Part of what we're doing is we're looking at a model in which we use maybe a session every couple weeks, and then a capstone course that will invite faculty from Penn State's main campus as well as our colleagues in Hershey to really dive deeper into those diseases that we may not see or even diseases that we may have or patients that we may have worked with. Being that we have the clinical immersions up front, it gives us a little bit of scaffolding, right? So we can build on those that learning that we've had. So we see even a diabetic patient, we didn't read about that, but we have, you know, we didn't read about them in a book, we've met this patient. Taking it a little bit further with a biochemist, you know, I remember Mr. Jones and now I want to keep pushing it further. Can you help me do that? And so that's one of the ways is kind of focusing on that basic science and making sure that we get those answers that we want, that we may not get from the IQ group sessions. Another good example are the anatomy sessions we're working to put together. We're collaborating with, again, faculty from Hershey, but as well as faculty from main campus. Something that we haven't really talked about, but we have a very small campus and limited resources, which again, we have to be very conscientious of. And so being a team or partnering up with people is something that we really enjoy doing, and it kind of goes back to interprofessional learning as well. But utilizing some of the facilities on campus to do cadaveric dissection, we have an echo pixel, which is kind of like a 3D machine. You can use CDs of scans of imagery and kind of work with that. Maybe working with some ultrasound, so Sonocyte, Sonosim, and kind of using all these resources to address those gaps and to continue to further our knowledge so that we make sure that we're comfortable with what we're doing and at the end of the day are ready to practice and take care of patients.